Welcome to Brightlight 2021. This study aimed to look at what outcomes were associated with joint care for teenagers and young adults with cancer. Before I start, I just want to say that this presentation represents independent research funded by the National Institute for Health and Care Research, the NIHR, under its Policy Research Programme. Rachel Taylor, the co-PI for this study, is funded through a Senior Clinical and Practitioner Research Award, and the views expressed are those of the authors and not necessarily those of the NIHR or the Department of Health and Social Care. So the teenage and young adult model of care in England has evolved over the last 30 years to be arranged in networks with 13 specialist TYA principal treatment centres or PTCs that form a hub linking to local hospitals or designated hospitals as they're termed. So young people receive aspects of specialist teenage and young adult cancer care wherever they are. Guidance proposed in 2005 specified that those aged 13 to 18 years received care in either a specialist TYA unit or, if they were younger teens, in a children's cancer unit, and those aged 19 to 24 needed unrestricted access to age-appropriate care. There was no evidence supporting this guidance. It was based on clinician experience and expertise. So in 2012, we started the national evaluation of this model of care. Centre to the evaluation was a cohort study of 830 young people newly diagnosed with cancer between 2012 and 2014. The study compared where young people had received care in the first 12 months after diagnosis, whether they'd had all, none, or some of their care in a specialist TYA unit through a longitudinal survey administered 5 times over 3 years. Young people indicated survival alone was not the best outcome, so we looked at a range of outcomes and health metrics and was surprised to find that the group who fared the poorest were those who had some of their care in a TYA unit, but also in either a child or adult unit, so the some care group. And this was despite correcting for a range of confounding factors. Fortunately, Brightlight was a comprehensive evaluation consisting of 6 interlinked studies, so we were able to look at the qualitative aspect, exploring the culture of TYA cancer care. And this showed that for a culture to develop, you needed effective leadership, competence in caring for young people, buy-in from the wider MDT, and a critical mass of young people. More importantly, this needed time to develop. It didn't just happen overnight. So how did we explain these results? Well, in collaboration with our Young Advisory Group, we proposed a number of explanations for these results. So in 2012, when we started Brightlight, many of the principal treatment centres were just starting to develop. So we surmised that over time, as the culture evolved and the relationships grew across the networks, care would become more coordinated. There were also other professional developments since 2012, such as nurse leadership meetings, university providing TYA-specific education, and there was a range of national and international conferences that enabled healthcare professionals to come together to share best practice. However, the results from Brightlight were not available until 2019. Which unfortunately coincided with the release of the draft specification that was directing how services in England were to be commissioned for young people with cancer. And central to this specification were for networks of care to be formed called Operational Delivery Networks, or ODNs, who were responsible for developing models to deliver joint care. Exactly the same model of care we showed was associated with poorer survival and quality of life and cost more to young people and the NHS. So this led us to conducting a further evaluation to explore our hypothesis that a more evolved culture of care in 2021 in comparison to 2012 would lead to better coordinated care and hence better outcomes for young people. So Brightlight 2021 has three separate streams of work. So the first was looking at the young person's perspective, and this was to determine if differences existed in outcomes for young people who received joint care. So a cross-sectional survey was conducted with young people who were newly diagnosed with cancer 4 to 6 months after diagnosis, and we related the proportion of TYA principal treatment centre care received in the first 6 months after diagnosis, and this was conducted in October 21 to December 22. So we conducted this study in 10 principal treatment centres in England, but we also collected data in Wales and Scotland. We're just presenting the English data here at the moment. So young people were recruited through the TYA multidisciplinary team, which enabled us to then recruit nationally. And we collected data through an adaptation of the Brightlight survey. So this was either online or a paper self-report. And our analysis, we used self-reported location of main place of care, so whether they were in a principal treatment centre or in a child or adult unit. And we used a mixed methods model, which we adjusted for the same confounding factors as we did in Brightlight. So this included gender, age at diagnosis, ethnicity, type of cancer, prognosis, presence of any long-term condition prior to cancer, socioeconomic status, choice about where to receive treatment, and geographical location. And these were all variables that were shown to be confounding to quality of life. So we recruited 240 young people from England. The majority were female and the majority were 19 to 24 years. And their main cancer types were lymphoma and carcinoma. So there was no difference in quality of life, social support, anxiety, depression, or illness perception. But those who had no TYA specialist care had higher perceived health status. And if young people were in an adult cancer unit, this is one of the reasons we explained for this, we felt that they would be surrounded predominantly by older people. So in comparison, they may perceive themselves to be in better health. Our second study focused on healthcare teams' perception of the coordination of care between the specialist TYA unit and the other hospitals in their network. And this was a rapid ethnography study guided by Demer's structuration model of healthcare collaboration, which is a process of giving structure or organisation to care and focused on the relationships between professionals and the interactions they had with the healthcare system. So this study was conducted in 10 principal treatment centres in England, but also in Wales. So we recruited across 58 healthcare professionals who majority represented the principal treatment centres, but we did have staff who worked in designated hospitals and those that worked across both. Most were nurses, but we did have representation of other members of the MDT. So data were collected through first the researcher contacted the TYA lead in each network to map where the services were delivered, where care was and young people were treated, and then identified key professionals to contact to take part in an interview. And health professionals were then participated in semi-structured interviews, which were analysed using the real RAP sheets and framework analysis. So the results are presented according to the structuration model to show coordination, to show inter-organisational collaboration, which is organised around these 4 dimensions with 10 particular indicators. So these first 2 dimensions, shared goals and vision and internalisation, represent relationships between individuals, whereas formalisation and governance refers to organisational relationships. So first, shared goals and visions. Professionals in both the specialist and designated hospitals wanted to identify patients quickly so they could begin the pathway that a specific cancer treatment required. They wanted to give young people a choice about where to be cared for and preferably use the joint care model to accommodate their needs. However, there were factors that limited this freedom of choice and hindered early care. Professionals in all care settings had a clear common goal of providing patient-centred care, but practices and priorities varied, indicating that while there was an intent to be patient-centred, professional and organisational interests still drove decisions of where young people's cancer care was based. Internalisation refers to the awareness professionals had on their interdependencies, sense of belonging, and knowledge of each other's values. In relation to joint care, there was a perception that this was limited in clinical activities. It was focused more to supportive and psychosocial care. Joint care depended upon trust and relationships, which needed to develop between the professionals in different organisations. But a barrier to this, mostly as a result of the pandemic, were restrictions to social interaction. So, for example, the extended use of technology resulted in virtual meetings as preference rather than in-person meetings. Other things that impacted on the development of relationships were perceptions of the specialist units considering their care superior. As one professional noted, the regional hospital had lower quality scans or lab results than we do. Finally, communication was sometimes viewed as not being optimal between the specialist and regional hospitals. There was attempts to share information and coordinate care, and this was often using TYA outreach staff, but these activities were not consistent or standardized, and there was quite a big geographical variation. So at organizational level, formalization refers to the extent documented procedures communicate desired outputs and clarifies expectation and responsibilities. While there were formal processes in place to refer patients into a diagnostic pathway and into a specialist unit, holistic TYA cancer care relied on informal processes, so there was often incomplete information exchange between the PTC and designated hospitals, and the infrastructure, which did not meet young people's needs or was used inappropriately. Outreach roles and information systems existed, but there was evidence that formalisation mechanisms were still in the process of being negotiated or constructed, and a good example of this was having honorary contracts in place or being able to access IT. And there were efforts to enhance information exchange through the MTTs. However, the NHS IT infrastructure was a massive barrier to the care continuum. Multiple EHRSs, electronic health record systems, which were not standardized across organizations, resulted in a lack of integration between data systems and gaps in the information exchange infrastructure. Professionals therefore faced challenges in information exchange and had difficulties in getting timely updates and feedback. This contributed to ongoing issues with collaboration and trust building. Finally, leadership refers to governance that supports collaboration. And there was no unified and clear leadership structure that effectively drove collaboration between the PTC and designated hospitals. And this became apparent with aspects of TYA cancer care being delivered. For example, the outreach nurses identified and followed up patients, but they weren't in charge of coordinating the full continuum of care. A disease-specific CNS led the young person's appointments and their blood tests, while the TYA CNS supported their psychosocial journey. So from a clinical perspective, named clinicians coordinated care for young people's chosen place of care. Hence, coordination of care was split between stakeholders within their place of care. If patients chose joint care, there was no established model of coordination nor leadership, not even for joint clinical decision making, as hospitals had their own site-specific MDT. And furthermore, there was no mention of senior roles or central authority nationally or similar, and no leadership structure across the network. So our third section of analysis is not yet completed and the results have not been reviewed and interpreted by our young advisory panel. So we can't make any definitive conclusions, but based on our current analysis, effective coordination of care requires a mediator, which was provided for by the outreach team. However, there was regional variation in how this was provided. We found that compared to the 2012 Bright Light cohort, there were no differences in outcome according to place of care, which we think could in part be explained by more coordinated care. The lack of leadership will most likely to be overcome as the draft service specification circulated in 2019 was finally implemented in 2023, with some leadership roles appointed to implement it. However, we have to ask if the resources available are going to be enough. And if the government is commissioning a service that requires coordinated care, appropriate funding should accompany it. The outreach workforce, which has emerged as an important factor for coordinated care, requires considerable investment to ensure it is equitable across England and that it's sustained. So no man is an island. So Bright Light 2021 comprises of a wide team. Most important are our young advisory panel who have been with us since the beginning of Bright Light in 2012 and have advised all the way through on this study. And I want to thank all their help. If you have any questions or have any comments, please feel free to contact the Bright Light team at uclh.brightlightnhs.net. Thank you.